So this is questions on diabetes. So diabetes practice questions. So I go through the questions. If you know the answer, just I know the answer is right there, but just put it down and the things you're able to remember on each of the topics. What is the most common type of diabetes mellitus? Most common. That one is a simple giveaway question. An answer. The answer is type 2. So type 2 diabetes is the most common. Which lab test assesses long-term glycemic control? So what do we use? So we have the random blood glucose, oral glucose tolerance test, hemoglobin A1C. So I kind of like how I mentioned these four things: fasting plasma glucose. So please take note of this. So that is the the thing. So hemoglobin A1C is it shows the average glucose taking 2 to 3 months. Okay, so also remember the fructosamine test. Yes, it's another one, but that fructosamine test is different from this one because the that one it can check the blood glucose, the storage for the past 2 to 4 weeks. 2 to 4 weeks. Okay. Okay. Let's continue. So please remember that it just is we call it a fructosamine test. So the fructosamine test it helps to check the way A1C. So if they're asking you the one that will help you to check or to give the recent blood sugar level, which I said some will tell you between 1 to 3 weeks, some other will tell you between 2 to 4 weeks. They are still correct. So fructosamine test, we use it to monitor the average blood glucose level. So if you need something within 1 to 3 weeks, okay, that will be the best choice. So it provides a more rapid assessment than the A1C. Okay, so if you particularly need it for assessing the effectiveness of a recent treatment changes, so like I said, it's a short period of time. So that would be the best choice to use. But other than that, A1C gives you 2 to 3 months. So remember the difference between both the A1C and the fructosamine test. So if the question asks you about the blood test we use to monitor the average blood glucose within 1 to 3 weeks, or like I said, there are some options in the questions, but anything within 1 to 3 weeks or 2 to 4 weeks, something like that, that is the fructosamide test. But if they're asking you 2 to 3 months, then that will be A1C. What is the first line medication for type 2 diabetes? What is the first line? Everybody knows this. This is simple, very easy to remember. The answer is metformin. Metformin. So please remember metformin. And metformin, we use it in case for more emphasis for the exam. We use it in PCOS. If you remember, not just for diabetes. I'm just putting for more emphasis in case they ask you in the exam. We use metformin. So if you remember the medications that we use for PCOS, we use the oral contraceptive or the contraceptive which we said we use to regulate their period. We use the one um, to um, to induce their ovulation. We give them metformin. Metformin will help to lower their high insulin level. Okay, because with PCOS, you want to lower their high insulin level, and it will help to regulate their hormone. Okay, so by reducing the insulin level for people that have PCOS, metformin them can help them to have their regular period. So it helps with their insulin resistance. That is simple. But also remember the side effects of metformin. I know this is a practice question, but sometimes I kind of like to emphasize more on the things you can see in the exam. The side effect of metformin is high yield in the exam. Examples is the GI side effect, gastrointestinal side effect, which is your diarrhea, your nausea, your metallic test. Please don't forget metallic test. It gives them that metallic test in the mouth. Metallic test. And this is the reason you have to start with low doses and you can gradually increase. Okay. Then another side effect of metformin is your vitamin B12 deficiency. Very high yield. Vitamin B12 deficiency. Long-term use of metformin can interfere with the absorption of vitamin B12. So it can affect vitamin B12 absorption, thereby leading to fatigue and nerve problem and anemia. Okay, it can lead to fatigue, it can lead to nerve problem, it can lead to anemia. So it's very important that when somebody is on metformin, you are also monitoring their vitamin B12. Another important thing is the some side effects that can be rare, which is the lactic acidosis. Lactic acidosis. So we say that is very is a very rare but is a life-threatening complication. When somebody is on metformin, lactic acidosis can build up in the bloodstream. So the risk is higher when people have a significant kidney disease. So, like we said, that is why we also need to monitor their kidney. Very important. Also, remember that metformin is safe in pregnancy. Is safe in pregnancy and breastfeeding mothers. So please remember that. And for metformin, metformin does not cause weight gain. We have mentioned this. It does not cause weight gain. So it may help with weight loss. It's not that it's a weight loss medicine, but just remember it does not cause weight gain. So it can help. Okay. So how does this metformin work? Metformin is one of the medications they can ask you of the mechanism of the action. The first thing it can do is to reduce glucose production. So it decreases the amount of glucose your liver is producing. So the liver is producing, when somebody have diabetes, the liver is producing a lot of glucose. So what will metformin do? Metformin will reduce the amount that is being produced. Okay. Then another thing metformin can do, because we went through the mechanism of action, it can decrease glucose absorption. It's not just that it is reducing the amount that is produced, it is also decreasing the amount of glucose that is absorbed. It lessens the amount of sugar that is absorbed from food in the intestines. Then the third thing um, metformin can do is it increases insulin sensitivity. It improves your body's response to insulin. Okay, the hormone that controls the blood sugar. So three things I mentioned because this is high yield mechanism of action for metformin. It reduces glucose production, it decreases glucose absorption, it increases insulin sensitivity. Okay, please remember those three things. It can also, we talked about the side effects, we talked about the lactic acidosis. Remember everything I mentioned. Which complication is most associated with poorly controlled diabetes? Poorly controlled diabetes, the answer is peripheral neuropathy. Peripheral neuropathy. So peripheral neuropathy is one of the things you need to educate a patient when they have diabetes. They may start having those numbness, those tingling. Okay, that is peripheral neuropathy. So chronic hyperglycemia damages the peripheral nerves. Which insulin type has the fastest onset of action? Which one have the fastest? So please remember, under the insulin classification, um, if you remember that we say that we have classification of insulin. Insulin can be classified based on the onset, on the peak action, or the duration of the effect. So you can have the rapid. This is what some people don't remember because they just think that is a short acting intermittent. No, we have the rapid acting insulin, we have the short acting insulin, then we have the intermittent acting insulin, then we have the long acting insulin, and we have the ultra long acting insulin. Then we have the combination insulin. So I have all the videos on this topic, but what I'm doing is just a recap because of the questions we are going through. So listen to those videos again. Under the rapid acting, you can be asked, one of the questions you can be asked is, all of the following or which of the following is a rapid acting? So the rapid acting or the fastest one, okay? So you have the rapid acting. Under the rapid acting, that is where you have your Lispro. So the answer is Lispro. Then you have the short acting. So the rapid acting is usually the onset is between 15 to 30 minutes. 15 to 30 minutes. So what is the peak? Because one thing about insulin classification, you need to know the onset, you need to know the peak, you need to know the duration. They may not necessarily ask you all this in the exam, but that is how to be able to know which one is the rapid acting. So the onset of rapid acting is between 15 to 30 minutes. So don't get it confused with the short acting. The short acting is your regular insulin, and that is where I always remember it as the letter R. So when you have like Humulin R, Novelin R, the regular R for regular. So that is your short acting. Those ones are your onset of 30 minutes. Then before you have your intermediate acting. The intermediate acting insulin is your MPH, the MPH. So that is the one that covers insulin need for almost half of the day or the overnight. So because those ones, the duration is 12 to 18 hours. So that is why they usually give it in the night. It can cover all through the night. Then we have the long acting. Long acting, that is where you have your Lantus. The long acting, it can cover the insulin for a full whole day. That is the long acting. And then you have the ultra long acting. Okay, so but another thing you need to remember, because you can be asked, when a patient is diabetic and they start having 2 digits, let's say they start having 10 point something, okay, 2 digits, the answer is you have to start them on what? Long acting insulin. So that is why you will see they start them on Lantus, okay, long acting insulin. So please remember everything we say because it's very important. Please don't forget, it's very important. So sometimes they call it a basal insulin. Don't forget that the basal insulin is a long acting insulin. So when you hear or when you see it in your question, basal insulin, that can be your long acting insulin. So the basal insulin is those ones which is your MPH, which is your long acting insulin, which is your long acting insulin. Those, it can be any of those three. Okay, so that is your basal insulin, and they are the ones that can cause a severe hypoglycemia. So please remember it. If they don't use the word long acting MPH or ultra long acting, they just call it basal insulin. Please don't forget, basal insulin is a long acting insulin, so it can either be what? Intermediate acting insulin, which is your MPH, or it can be long acting insulin, or it can be ultra long acting insulin. So we covered insulin. Which value meets diagnostic criteria for diabetes? So which of the following meets the diagnostic criteria for diabetes? So one thing about diagnostic criteria for diabetes you must know, because it's very important, because they usually ask that what is the diagnostic. So this is very simple, because the reason it's very simple is that you can always figure out which one meets the criteria for the. So we have, according to American Diabetic Association, remember everything is guideline. We have a American Diabetic Association. They recommend the diagnostic criteria for diabetes, and the three diagnostic criteria, or I will say four, okay, they recommend is, the first one is the A1C, okay, the A1C. So the A1C is when it's greater than 6.5. So that means the one I have in the question is less than 5.7. So this is not, it shows the person is not diabetic. So that one is out because it's a normal value. If it's greater than 6.5, so that is the first criteria. Another criteria is if it's greater than one, if the fasting blood sugar, if the fasting blood sugar is greater than 126, and that is why that is the answer. Okay, so that is the answer. So that is the one that met the criteria for the for the diagnosis of diabetes. Another criteria is the OGTT. OGTT. What is OGTT? Oral glucose tolerance test. Some of you have undergone this test, especially for a pregnant woman. So that is the 2-hour plasma glucose. 2-hour plasma glucose. So that one should, when it's greater than 200, greater or minus 200. Then the last one is the random plasma glucose. Random plasma glucose. So remember the four criteria: A1C greater than 6.5%. We are talking about according to American Diabetes Association, ADA, American Diabetes Association. They recommended four criteria for you to make diagnosis of diabetes. So when you have a patient that you think that patient may be diabetic, you can order. So if two or more tests meet the criteria, a diagnosis of diabetes can be made. So out of these four things that I mentioned, if patient has two or more, so remember, there is a medication that we said that can cause hyperlipidemia, that can cause hyperglycemia, and that medication is thiazide diuretics. So you have to look at your question very well, because they can put some questions out there and tell you a patient is taking like 5 medications. They can list the 5 medications, and they can ask you which of these medications is worsening their hyperglycemia, or can cause hyperglycemia, or can elevate any of this level we mentioned. So what are those levels again? A1C greater than 6.5, fasting plasma glucose greater than 126, 2-hour plasma glucose greater than minus greater or less than 200 mg DL. Then random plasma glucose greater than or minus 200. All these things is in the video. So please remember, pre-diabetes is diagnosed when the blood glucose level are higher than normal, but not higher for a diabetes. So let's say, for example, when you do the blood glucose level, some people, when it's higher than normal, it can be pre-diabetes. But other things to remember is that you also need to consider their age, their ethnicity, and the family history. Okay. And what are those symptoms of diabetes a patient can complain? Excessive thirst, frequent urination, unexplained weight loss. So please, again, according to American Diabetic Association, know those criteria. I've spent so much time explaining it. Please know those criteria because you can have it as an options. You need to figure out which one is correct. Which oral medication increases insulin secretion? Which one increases insulin secretion? So the answer is D. Know the mechanism of action. Some of all these medications, we have talked about it. So we are just doing a recap. So look at it again. The sulfonylurea, we say that the sulfonylurea, it can also, examples of those sulfonylurea is your glipizide, glimetredine. Okay. We say that the side effect is mostly weight gain, upset stomach, nausea, and vomiting. Okay. So when you compare this sulfonylurea with metformin, metformin is usually the first line. We have said it because it has a lower risk of hypoglycemia and weight gain when you compare it with sulfonylurea. So if somebody asks you, why are you giving a patient metformin instead of sulfonylurea? Metformin has more lesser risk for hypoglycemia and weight gain. Okay. And sometimes some studies have also shown that sulfonylurea can increase the risk of cardiovascular risk when you compare it with other diabetic medications. What is the rare side effect of metformin? Rare side effect. We have answered this, that the answer is lactic acidosis. Lactic acidosis. We have answered it. So, lactic acidosis is rare but is a serious condition. Why? The body is producing too much lactic acid, leading to drop in the blood pH. Okay. So, metformin is one of the medications that can cause lactic acidosis. So, when somebody have lactic acidosis, it will make the kidney not to be working properly. So the kidney is not working properly. So when kidney is not working properly and they cannot remove this lactic acid from the body, it can also affect the liver. So this is two things you need to know. When it comes to metformin, metformin can affect the kidney, metformin can also affect the liver. Okay. When metformin is given, that is why, if you know the guideline of giving metformin, normally when you max out, they usually start them with 500. They can do 500, they can do 1000 BID, which is basically 2000. Once they max out metformin, they have to start them on They can combine it with another medication depending on the question you are asked in the exam. So let's say, for example, the patient A1C, the goal is to be less than 6.5, like we know. But the patient A1C is still like maybe 8. This can be your exam question. Okay. It's not yet double digit. The double digit, I mean like 10 point something, double digit. Okay. I'm teaching you the guideline and it's exam question. So what do you do? The answer will be you can add another medication. So you can add glipizide. So they can actually be on metformin and glipizide. But we say that if they becomes 2 digit, if it is 2 digit, then you can now give them what? Metformin and basal insulin. And I explained to you what is basal insulin. They are those long acting insulin. So lactic acidosis is a serious condition, like I have mentioned. Metformin is used to treat type 2, but it can cause lactic acidosis. So how does this lactic acidosis occur? Because the kidney are not working properly. So metformin can affect both the kidney, it can affect the liver. Okay. So what are the things that can cause somebody to develop the risk of lactic acidosis? It can be their kidney. If they have a renal impairment, if they have a liver problem, if they have dehydration, advanced age, high doses of metformin. So please, in as much as metformin is the easiest or the first line for diabetes, it's very important they monitor lactic acidosis. So, what are those signs of lactic acidosis? It can be like muscle weakness or pain. It can lead to fatigue. It can lead to nausea and vomiting. It can be diarrhea. It can be confusion. It can be seizures and what? And coma. So, please, metformin. That is why when you are talking about metformin, metformin is not just affecting the kidney, it's also affecting the liver. Which complication is evaluated with a fundoscopy exam? So we talked about um, hypertensive retinopathy and diabetic retinopathy, if you remember. So the mnemonic that I used for hypertensive retinopathy was CAR, C-A-R. So C is copper wire arterial, A is AV nicking. On a fundoscopy exam, the artery crosses the vein in a fundoscopy exam. Okay, so remember that the and then retina retina hemorrhage. Okay, so that is your hypertensive retinopathy. So under the diabetic retinopathy, you have that retinal hemorrhage, and you also have the AV nicking. So what is that AV nicking? Is the hardened retinal artery is compressing the retinal vein. So you can say when the artery crosses the vein in the fundoscopy exam. Okay. Then we have the diabetic retinopathy. What are the diabetic retinopathy? The mnemonic is MCR. MCR. What is M? Microaneurysm with neovascularization. Then C is copper wire. Is the cotton wool spot. Cotton wool spot. And the R is the retinal hemorrhage. Please remember these two retinopathies, the hypertensive retinopathy and diabetic retinopathy. And one thing I say is that it's not under your watch, not under your watch, should your diabetic patient or hypertensive patient becomes blind, not under your watch. Please, as a provider that knows what he or she is doing, not under your watch. When a patient, this is one of the exam questions, when a patient is diabetic, when a patient is hypertensive, you need to refer them to ophthalmology. They need to follow up because they can have any of these retinopathies. For hypertensive retinopathy, the answer is a copper wire arterial AV nicking retinal hemorrhage. If it is diabetes, it is MCR, microaneurysm, cotton wool spot, and retinal hemorrhage. Which is a macro? So the answer to this question is your what? Diabetic retinopathy. Which is a macrovascular complication? Macrovascular complication of diabetes. The answer is peripheral artery disease. I'm not here to talk about peripheral artery disease, but remember, peripheral artery disease, also known as PAD, PAD, okay, is a very high yield in the exam, PAD. So, what do you need to remember here? You need to know that patients have that hairless, shiny, intermittent claudication. So this is caused as a result of atherosclerosis. It's caused as a result of plaque formation in the artery. So always remember that they ask a lot of questions on PAD, and they also have a lot of questions on venous insufficiency. So both of them, I mentioned it that the one for PAD is caused as a result of blockage of the artery. But the one for venous, because this is the most common thing we see in a primary care. So patient will ask you about venous insufficiency. It's as a result of the problem in their vein, the vein valves. It is preventing proper blood return to their heart. So I just make it simple for the patient. In peripheral artery disease, I just tell them that there is a blockage, which is that atherosclerosis, which is that plaque. Okay, there's a blockage in their artery, and it's making the blood not to flow very well. So because of that, they always have that intermittent claudication, which is relieved by rest. I know this is kind of confusing because in the exam, one of the education is tell them to exercise. Exercise is very important. Yes, patients have intermittent claudication because there are stages of PAD, but I'm not here to talk about it. In that stages of PAD, we also have that intermittent claudication. We also have the rest pain, rest pain. So at that point, they have so much blockage that even when they are resting their legs, they still have a lot of pain. Okay. But in venous insufficiency is caused as a result of just a simple way. The vein valves, the valves in their vein is not functioning properly. So because it's not functioning properly, it's causing the blood to pull or to be in the lower extremity. So under PAD, they have to do all those angiogram to be able to remove the blockage. But under PAD, under venous insufficiency, they have to raise their leg because they have a lot of swelling, and that swelling and that discoloration. Please remember those things. Venous insufficiency, you have swelling, you have discoloration. Under PAD, you have hairless, shiny lower extremity. And the what we use for diagnosis, we call it ankle breaker test, which is the ABI. So they have to do ABI, and we know the guideline for ABI. If it is less than 0.5, they cannot put them on any form of compression. The normal one is greater than 0.9 for them to be on compression. Okay, so compression therapy is mostly, and lifestyle changes is the mostly important thing for venous insufficiency. So another important thing is that they can do an ultrasound. So remember, when it comes to PAD, their leg is usually cold, and their pulse is diminished. or weak. But under venous insufficiency, their skin is warm to touch. You can just say warm to touch or normal, warm to touch or normal, and their pulse is weak or normal. But in PAD, their pulse is weak or absent. Is absent. Which drug which drug class increases UTI risk in diabetes? So the answer is SGLT2. SGLT2. What is the hallmark symptom of diabetic ketoacidosis? Please, 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 please. This question can be in so many forms in the exam. Diabetic ketoacidosis. So it's very, very important, and we always see it in a type 1 diabetes. Okay, in type 1 diabetes. So which is it? The hallmark. The hallmark is what? That is that cosmal respiration. Some of us might have heard this thing in our NCLEX exam. So that is the diabetic ketoacidosis. That is the deep labor breathing compensates for the metallic acidosis. So patients that have type 1 diabetes, they are always at risk of diabetic ketoacidosis. And this diabetic ketoacidosis, it develops when the body cannot make enough insulin. So when the body cannot make enough insulin, a hormone that helps the sugar to enter cell for energy. So the body is not making enough insulin. So what will happen when the body is not making enough insulin? The fat is broken down for energy. So they start breaking down fat for energy. So this will cause acid, those acid that is called ketones, to start building in the blood, and they will collect in the urine. So this is the one of the highest risk for people that have type 1 diabetes, okay, or people that is missing their dose for insulin. This is a medical emergency. It's a complication of type 1 diabetes. Okay, so another thing they always describe it in the exam, a diabetic patient, like we say, type 1, very tasty, frequent urination, stomach pain, tiredness, and shortness of breath. The major word there is what? Fruity breath. Like their breath smells like a fruit. Fruity breath. So they can ask you a question, a patient have fruity breath. What do you do for this patient? The first answer is what? Just check their blood glucose. Okay. So it is very, very important that they have to be sent to the hospital. Diabetic ketoacidosis. It can lead to loss of consciousness. It can lead to death. So that is, they have that cosmal respiration. And like I said, it can also be a question under patient has a fruity breath. What do you do next? The answer is to check their blood sugar. So as soon as you check their blood sugar, you send them to ER. Which lab value monitors nephropathy? Diabetic nephropathy. So that is your urine microalbumin. We mentioned this urine microalbumin also under hypertensive medication, because like I said, when somebody has a hypertension and diabetes, or they start having that proteinuria, that you need to do what? You need to start them on ACs or ARBs. What is the benefit of GLP-1 receptor agonist? This is one of the things we learned. The answer is that it reduces cardiac or cardiovascular risk. GLP-1, GLP-1, it reduces what? Cardiovascular risk. Please remember that. It reduces cardiovascular risk. So it's usually helpful. It has shown that it has helped to reduce cardiovascular risk like a heart attack, stroke, and cardiovascular death. Please remember that it reduces cardiovascular risk. Very high yield. What is the best initial lifestyle advice for newly diagnosed type 2 diabetes? I think this is very easy and take away. The answer is just they need to lifestyle modification. So you are not starting them on insulin immediately. Remember, the insulin starts when they have their A1C double digit. Okay. The answer is just they need to begin lifestyle management, which is low carbs diet and increase physical activity. That is always the first line. Which of the following is indication for metformin use? So, which of the following is contraindication for metformin use? Metformin use. The answer is renal impairment. Renal impairment. We say that when they have a renal condition, when they have a condition, they need to avoid metformin use. So we have more questions for you to practice. You can go to your book